Good afternoon, everybody. My name is Moises Agosto Rosario, and I'm the Director of Treatment at EMAC. And today we have a webinar from our HIV 50 Plus Strong and Healthy program. And the webinar, we're very excited about it because it's about policy issues that need to be addressed in terms of people aging over the age of 50 living with HIV and the challenges that present in terms of the delivery of care, the delivery of services, and also other important issues like mental health and structural issues that will need to be addressed in order for us to have a better response to this population, which it is the first cohort of individuals that are HIV positive, that are over the age of 50, healthy and aging. So it's important that we address any advocacy or policy issues and the recommendations that we may have. So today we have two great panelists. They are dear friends, and I have a great deal of respect for each one of them. And I'm very, very, very thrilled that they accepted to be part of this webinar and talk to us about these issues based on a report that they just published. Excellent report addressing issues of policy and the aging with HIV population. I'm going to introduce them. So we have Shan Bland, and Shan is a senior associate at the O'Neill Institute for National and Global Health Law at Georgetown University Law Center and works on HIV and AIDS law and policy initiatives. Shan manages diverse projects to assist policymakers and HIV community stakeholders access policy options for sustaining and adapting the Ryan-Y program and implementing the National HIV and AIDS strategy and the Ending the HIV Epidemic initiative. He also leads projects related to the development of pre-exposure prophylaxis PrEP among communities of color and adolescents and the impact of laws and policies on the health and safety of people who engage in sex work. Shan holds a Juris Doctor from Georgetown University Law Center and a bachelor degree of art and psychology and German studies from Yale University. Welcome, Shan. We also have Jeff, who is a longtime friend, dear friend as well. And Jeffrey Crowley is a distinguished scholar and program director of Infectious Diseases Initiative at the O'Neill Institute for the National and Global Health Law Center at Georgetown Law. Mr. Crowley is Jeff Crowley is a leading expert on HIV and disability policy. In fact, from 2009 to 2011, he served as the director of the White House Office of National AIDS Policy and senior advisor on disability policy. As President Obama's chief HIV and AIDS advisor, Jeff Crowley led the development of the first comprehensive national HIV and AIDS strategy for the United States. From 2000 to 2009, Mr. Crowley was a senior research scholar at Georgetown University's Health Policy Institute and subsequent to its founding. He was a senior scholar at the university's O'Neill Institute, focusing his work on improving health care to people with disabilities and chronic conditions through improvements to Medicaid and Medicare. As you can see, we have a very knowledgeable panel. And with that, what we are planning to do today on the agenda is we will go to the presentation, and then after that, we will have time for some question and answer from the audience. So with that, I pass it to Jeff and Sean.
Great.
Thank you, Moises. I'm actually going to be very brief, but it is a pleasure to join you and Damian and all the people on the call. And I can't see who's with us, but I'm sure many of them are friends. I just want to quickly tell you a little bit about how we work at the O'Neill Institute. why we took on this issue and what we hope comes of it. And Sean's going to really present the findings of our report. So the O'Neill Institute for National and Global Health Law has a diverse array of scholars that work on it, as it says, global issues as well as domestic issues. But Sean and I work together on our HIV policy project. I also oversee a broader range of infectious disease programs, hepatitis and other things. But Sean and I work very closely together, and we often think of our role as synthesizers and translators. So we often play a role of convening diverse stakeholders to tackle pressing issues for the HIV community. And we like to think that we can bring together diverse parts of our HIV community, including people with HIV, people at risk, healthcare providers, government officials, and others, and really have honest conversations and tackle them. But when I say we're synthesizers and translators, I think sometimes you hear a lot of information and you don't know what to do with that. And I think using our experience working in Washington, working with government, have some thoughts about how we take voices we hear from the community and say, what are the actionable things that we can do and should be pushing for? And really all of our work we do with a broad range of community stakeholders, including NMAC and others. So a couple of years ago, I started doing a little work in this area, and then Sean and I convened a meeting, and then so we produced this follow-up report. But I want to say when I first got started, I was struck, and I also know when we had our convening, some of the national policy advocates were also struck, and it's really troubling, just the level of despair experienced by so many people who are aging with HIV, people 50 and older, but feeling that, you know, in some ways our movement's forgotten them, or, you know, just feeling neglected in some ways. And, you know, I feel terribly about that. And I think we all need to acknowledge that and do better. The other observation I'd make is that some of the challenges we face are so big it can be immobilizing. So in all the work we do, but in this report as well, we tried to sort of say this is a huge topic, but here's a manageable number of recommendations, and Sean can go through them. But what I would say is there's a lot we can do and must do. We may need more resources. So we're certainly not telling people you don't advocate for things you need, even if they're new things. But the other point I would leave you with is with the existing programs and services and resources we have today, we can do better to deal with the needs of people who are aging with HIV. So I'll end here and turn it over to Sean, but you know, to any of you that are feeling like you're not important in our community or somehow you're not getting the attention you need, I think we're committed to working with all of you to address that, and we all can and must do better. Sean?
Great. Thanks, Jeff, and thanks Moises and NMAC for inviting us to present today. Again, my name is Sean Bland. I'm going to take you through our report. So this is going to be kind of a more formal webinar for at least the first part of the presentation. So I'll kind of go through some slides, take you through some of the major findings and recommendations from our report. But we definitely want this to be as interactive as we can have it be. So please utilize the question feature to ask questions. We'll definitely get to as many questions as we can for the last kind of 20 minutes or so of our time that we have. Please utilize the chat feature to share comments that you have, experiences that you have. We really want to, again, learn from your experience and kind of figure out how we can, again, continue to work on these issues, maybe find ways to work together. Again, we at the O'Neill Institute kind of use our position at Georgetown, relationships that we have to convene folks. So maybe future convenings could be something that we look at. And just as kind of work that we have coming up later this month, we're working with a number of people living with HIV networks and other organizations to convene a meeting focused on quality of care and quality of life. And so really thinking, again, not just about achieving kind of HIV outcomes, things like viral suppression, but really making sure that our HIV response is meeting the kind of comprehensive needs of people living with HIV and aging with HIV. And so obviously we'll talk about, we highlight a number of those issues in our aging report, but again, we're going to be doing continued work. And so we're happy to find ways to continue to obviously engage with folks like you and to learn from you and to partner with you going forward. So please ask questions about ways to do that and other areas for continued research and advocacy. So I'm going to share my screen now, which I hope you all can now see. All right. So again, the title of the presentation is the title of our report, Meeting the Needs of People Aging with HIV on the Path to Ending the HIV Epidemic. There's been a lot of focus on EHE, so Ending the HIV Epidemic, kind of an initiative that was first rolled out during the prior administration, and that obviously is going to be continued under the current administration at the federal level. But a lot of that kind of the focus of that initiative hasn't really been on kind of aging and older people living with HIV. And we know we can't really end the HIV epidemic unless we are, focusing on the needs of all people living with HIV, including those aging and over the age of 50. So this is the report that we released in May of this year. This issue brief, along with all other kind of O'Neill Institute HIV publications, are available on our website. So you have the link there below. Please, Google it or use this link directly to kind of access the report. Some of you may have already had a chance to look at it as well. So just kind of going through what are we thinking about in terms of these issues? Hopefully you can still see my screen. More than half of people living with HIV in the United States are age 50 or older, and that number is only going to grow. And we're seeing a growing number of people who are living and aging with HIV into their 70s and beyond. And I think that's a really important finding. It's an important development with the antiretroviral therapies that we have. Folks are now able to kind of live to this kind of longer lifespan, really equivalent to people not living with HIV. And so that is a major success that we should be celebrating. So it's wonderful to be able to have this conversation about aging with HIV. At the same time, we know that there are a number of challenges. So the burdens of HIV, of aging, and related health comorbidities, combined with a range of social and structural challenges that people aging with HIV face, it really necessitates a concerted effort to do a lot more and to do better, and not just focusing on HIV outcomes, but really focusing on having a comprehensive response that's aimed at treating comorbidities and improving long-term health and quality of life. So really centering this idea of quality of life and quality of health at the core of our response. So what does this response involve? Well, it's going to need to involve programs across the federal government, as well as programs at the state and local level, and also a commitment to health equity and intersectional policy approaches. So when we're thinking about programs across the federal government, certainly we need to be thinking about our HIV program. So we need to be thinking about the Ryan White program that's administered by the HIV and AIDS Bureau at HRSA. We need to be thinking about CDC HIV prevention programs. We need to be thinking about HIV programs at SAMHSA, at the Department of Health of Housing and Urban Development, so HUD, so HOPWA programs, VA programs, so Veterans Affairs programs. Those are all critical programs, and we'll talk more about them, and we have recommendations for how each of those programs can be doing more to meet the needs of older people living with HIV. But we also need to be thinking outside of HIV programs. And so if you look at the report, we have a full page on what are other programs across the federal government that aren't HIV specific, that are key to leverage those programs to, again, provide services, provide other resources there, so leveraging all the resources of the federal government. And some of those programs are through the Older Americans Act. We have programs also through the Program of All-Inclusive Care for the Elderly. It's also called the PACE program. There are also programs that are administered through the Administration for Community Living, as well as housing programs. So other housing programs at HUD, for instance, that aren't HIV specific, but can do a lot more to, again, meet the needs of older people, the housing needs of older people living with HIV. And so again, I'd love to have questions about experiences that you have, or knowledge that you have of these programs, how you've accessed them, challenges that folks have faced accessing these programs. I know one particular challenge is that a lot of the kind of aging needs that older people living with HIV face, they face them earlier than kind of other folks. So being able to access these aging programs, for instance, in your 50s, there are some programs have age cutoffs, and so that can sometimes be a problem for folks. And so making sure that, one, folks are not only aware of these programs, but that we have advocacy to make sure that these programs are really accessible to people age 50 and older, and maybe even younger than that, to make sure that we're really meeting the complexity of their needs. Again, we also need this commitment to health equity and intersectional policy approaches. So when thinking about equity issues, we need to be responsive to the experiences of people of color, to women, to trans folks, folks who are immigrants, folks who lack access to housing or face other economic or social challenges. And again, we need intersectional approaches that aren't just a medical model, but are also, again, meeting the needs around housing, employment, food assistance, and further. So those are critical and obviously are front and center of our report. I wanted to say that when we're thinking about older people living with HIV, I mean, Moises has already said this, as have I, in terms of we think about age 50 or older. This includes folks who are long-term survivors, so folks who have been living with HIV for more than 10 years. It's important to note, though, that long-term survivors can also include folks who are under the age of 50. And so for our report, we're looking at older folks living with HIV, which, again, includes many long-term survivors, but not all of them. And this group also includes many people who were diagnosed with HIV more recently. So in the last, most recently in a year or in the last 10 years. And so we do specifically highlight the needs of long-term survivors, and particularly the longest-term survivors, because many of those folks have distinct experiences compared to other people living with HIV, and particularly long-term survivors from the pre-HAART era. So from folks who were diagnosed with HIV prior to 1995 or 1996, so before we had highly active antiretroviral therapy. Those folks faced a range of challenges, and this slide highlights some of them. Receiving their diagnosis at a time when HIV regularly resulted in death. So many folks spent really the early years of their diagnoses believing that they would die, and in many cases watching partners and friends die of AIDS. They experienced, because of that, considerable amounts of trauma that is still difficult to resolve to this day. And some struggle with mental health problems as a result of that trauma. And also there are broader consequences. So a lot of folks who didn't plan for a future, who didn't imagine a future for themselves, still struggle with things like financial stability. So, long-term financial planning was not necessarily something that some folks were doing because they weren't expecting to live this long. And so making sure that we have an understanding of those issues, as well as the broader health consequences that some of the longest-term survivors face. So from being on the earliest HIV medications that had side effects that folks still face either disability or other health consequences from today. So making sure that we understand those unique needs and center those needs in our discussions of older folks living with HIV. So again, when we're thinking about this brief, it includes the needs of those folks, but again, it includes the needs of all people living with HIV who are age 50 and older and aging with HIV. Again, as Jeff mentioned, many folks really feel invisible within the broader HIV community. So we don't see necessarily the same representation in terms of when you go to national conferences, focus on aging issues, when we see just work that CDC or other programs are doing, really just a concerted effort to think about and center the needs of this population. And so many people feel that their issues are, again, kind of lower priorities. And so we want to make sure that we are, again, centering the experiences and the needs of folks, older folks living with HIV. And so when we think about some of I think the common challenges for all older people living with HIV, sometimes we just think, oh, folks who are over the age of 50 or age 55 are doing well in terms of viral suppression, which is often our primary kind of health outcome. And so we do have studies that show that, so CDC data shows higher rates of viral suppression and higher rates of retention and care for people living with HIV who are age 50 and older. But that kind of obscures some of the other challenges that folks are experiencing. And so particularly in terms of facing more health comorbidities that impact health and quality of life. But then also, as I mentioned, a range of social and structural challenges. So those include things like stigma, and again, not just HIV stigma, but ageism, so stigma around age, as well as other identities that folks have. So multiple forms of stigma, so around race, being low income, things like that. Experiences of trauma, experiences of isolation, social isolation. I think that was something that came up, really throughout every kind of research article that we read, as well as in the meetings that we've held and the engagement that we've had with older people living with HIV, kind of issues of social isolation, and just lack of support from family, friends, and community. So policy action is needed to improve the health of older people living with HIV. We have come out with these kind of, hopefully, a manageable list of recommendations, so 5 recommendations. Before I get into them, I want to just give a little broader context to some of the health comorbidities that that are kind of just presented in the literature that I think it's just really important to have front and center of our mind when we're thinking about this population of folks. So obviously we see higher rates of comorbidities such as cardiovascular disease, liver disease, diabetes, cancer, and even neurocognitive impairments in older people living with HIV compared to their age peers who do not have HIV. We also see higher rates of geriatric syndromes, so things like falls and frailty. And again, folks are experiencing these at in their 50s, or maybe even in younger ages in some cases, but they're experiencing these at higher rates. And these multiple comorbidities place older folks living with HIV at an increased risk of functional decline and disability. And also because of these comorbidities, folks are often taking multiple medications. So they're not just taking medications to manage their HIV, but they're taking medications to manage all these other conditions. And so I think a lot of folks would be familiar with kind of the cocktail of pills that folks would take in the 90s. So you might have 10 or 20 or more pills just to manage HIV. Nowadays, folks can manage HIV with just 1 or maybe 2 pills. But a lot of older folks living with HIV are still taking 10 or plus pills or maybe even 20 pills to manage not just their HIV, but again, all these other comorbidities. And that increases the risk of drug-to-drug interactions, which again have consequences for people's health. There are also a range of other kind of physical health challenges that folks face that includes oral health problems. So whether that be things like tooth loss, receding gums, deterioration of the jawbone, which can cause pain and other challenges with eating foods and maintaining a healthy diet. A lot of folks, I think that's often a kind of under discussed kind of need, oral health need, but if you don't have oral health, that impacts the rest of your health as well. Folks also face, older folks living with HIV also face significant mental health challenges, including higher rates of depression and other kind of mental health issues, at least compared to folks who are not living with HIV. And then we also see that folks have challenges just receiving the mental health care that they need. So they're often older folks living with HIV are less likely to receive mental health care than their younger counterparts. And so again, those are just some of the range of challenges, again, alongside the social and structural challenges that I mentioned. And so just thinking about those things, these recommendations are the ones that we've kind of put forth. And so we'd love, again, to have questions about them and to discuss them a little bit further with you. So the first recommendation is we need to develop models of care and prevention for people aging with HIV, and we need to train and equip the clinical and the non-clinical workforce. So again, there's a lot more that can be done in terms of clinical care, and we spotlight in the report one clinical program that I think has been very effective. So the Golden Compass program in San Francisco that really does have a comprehensive model of providing kind of HIV and kind of aging related care, so geriatric care. And obviously one of the challenges with that is, again, bringing that to scale, having continued financial sustainability of programs like that, and so making sure that we have the financial resources for those programs to exist and to continue to meet the needs, because the data suggests that they're not only acceptable and that people are retained in them, but they can actually have positive health benefits and kind of meet some of these challenges that I've already discussed. Number 2 recommendation, and I'll go into detail for each of these, but number 2 is expanding opportunities for older people living with HIV to make social connections through community-based programs that address isolation, stigma, and trauma. We also, in the report, highlight a number of community-based programs. So Oh Well, which is a program that's based in Baltimore, that serves particularly older women, particularly Black women living with HIV. We spotlight the Reunion Project and work that they've been doing, and as well as spotlighting the Positive Living kind of conference that happens. So just making sure that folks are aware of these types of community-based programs and activities that I think are really crucial for, again, meeting kind of the social needs of folks, but really also just supporting and empowering people living with HIV. The number 3 kind of recommendation is maintain Medicare Part D drug access protections. As an example, 6 protected classes, and also to expand a focus on high quality care and quality of life. There's particularly a lot more that can be done within the Medicare program to better meet the needs of older people living with HIV. So we highlight some specific recommendations there. Number 4, allocate more funding to programs that support financial security and access to employment, housing, food, and public benefits for the aging HIV population. And again, this is really getting at, again, this idea of quality of life. We need to address the kind of social determinants of health. So we need to address poverty. We need to address access to all of these other conditions that we know if we don't address them, we're not going to be able to support older people living with HIV, or really anyone, to have the health outcomes that we want to see. And then the last recommendation is to promote the meaningful participation of older people living with HIV in the Ending HIV Epidemic Initiative and in broader advocacy efforts. So I'm just going to delve into the first recommendation and talk a little bit more about it. We know that a lot more needs to be done in terms of making sure that our health system is meeting the needs of older people living with HIV. There is a critical role for the federal government to play. Obviously, we know that more work needs to happen also at the state and federal level, but the federal government, I think, can really utilize its leadership to help us to move forward and make some progress on this issue. And when we're thinking about the federal government, I mentioned, again, a range of non-HIV specific programs, aging programs, and others. But I think there is a particular role and priority that should be given to what can be done at HRSA, what can be done at CDC, what can be done at the NIH, and what can be done at the VA specifically. And so, and particularly, I want to just highlight the role of the Ryan White program through HRSA, because it really is, the center, the cornerstone of our kind of HIV response, our response for people living with HIV. And so it really can I think it is really uniquely positioned to kind of lead the way on HIV and aging issues. And there's a lot that HRSA's already done through the Ryan White HIV/AIDS program, and we highlight a number of those things in our report, particularly in terms of the Ryan White conference that they host each year. There's a much more focus in this past year, a number of workshops around HIV and aging. They had a whole aging institute at the 2020 National Ryan White Conference. They've released a number of resource guides that I think have been really helpful for thinking about what elements of care need to be brought together to meet the needs of folks aging with HIV, but then also thinking about, hey, how do we put together the type of multidisciplinary team that can provide the individualized care that we need to meet the needs of folks who are aging with HIV. And so we know it is going to take a team that doesn't just involve HIV specialists, but folks who are aging specialists, folks who are therapists, social workers, and others, as well as, again, folks who can provide all those kind of wraparound and support services. And so we highlight, again, what's already been done, but also spotlighting what can be done in the future. There are ways to leverage the Ryan White program, as well as particular components of the program, such as the AIDS Education and Training Center program, the Special Projects of National Significance, the SPINS program, and others to develop the kind of innovative models that we need. So really our first kind of sub-recommendation is around just increasing funding for the Ryan White program generally. So again, increased funding should be coming as part of the Ending the HIV Epidemic Initiative. So far what has been allocated, even in this past year, is not enough to meet the needs for even achieving the goals of the Ending the HIV epidemic, let alone to make sure that we're meeting the needs of older folks living with HIV. So we need to continue to support and advocate for increased funding, but also making sure that we identify areas for making changes within the program, as well as making changes to the program to support older people living with HIV. And again, when we think about changes within the program, there are a number of things that can be done to make sure that the program really is funding the types of services that older people living with HIV rely on and need. And so again, many of those services are, particularly the services I think where we have the most unmet needs, are things like mental health services, oral health services, as well as a range of the support services like housing and employment services. We know within the Ryan White program that there are some restrictions. There's a 75-25 rule that requires 75% of funding for certain parts of the Ryan White program to go to core medical services, and no more than 25% of that funding to support supportive services. But we know also within the Ryan White program that there's some flexibility. There's a waiver process to allow jurisdictions to spend more money on supportive services if that's what they need, and that could really benefit, I think, a lot of older folks living with HIV. So we need to make sure that we're working to support jurisdictions to submit those waivers if that's a need there, and to make sure that that happens. There are also a number of other things that I think can be thought of in a more structural way in terms of the program. So we might need to be thinking at some point around what are opportunities or needs to reauthorize the Ryan White program. So that 75-25 rule, again, there's a waiver, but we can do things through a reauthorization of the program to make sure there's even more flexibility for funding. As well, through reauthorization of the program, which would go through Congress, there could be opportunities to make broader changes to the program, such as changes that would allow Ryan White to pay for hospitalization. So right now, we're not able to use Ryan White funds for kind of inpatient kind of hospitalization care. That is something that is a need for a lot of folks, older folks living with HIV. And so particularly for folks who might be undocumented or who might not have otherwise access to those services, maybe there's a role for Ryan White program to play. Our second kind of sub-recommendation is around expanding the geriatrics and the HIV workforce and creating opportunities for improving their knowledge, skills, and collaboration in the care of older people living with HIV. I think what we know is that we don't have enough geriatricians, so folks with who are doctors with geriatric specialty, folks aren't going into that profession enough, so there are shortages. We are often able to rely on nurses and other health professionals, but there's a need for kind of doctors who have geriatric training. Similarly, we see a lot of doctors who aren't going into the HIV field. We see a number of fellowship positions for residency that are left open each year for infectious diseases. So we need to do more to make sure that we are supporting folks going into the HIV and geriatrics field, and ideally folks who kind of can be cross-trained in those issues. Changes that can be used to meet those challenges are, supporting kind of loan forgiveness kind of programs in a broader sense, or other ways to help folks to pay for their medical education. Making sure that we continue to cross-train folks on kind of the unique needs of older people living with HIV. And again, there are already resources that exist through HRSA, not only through the HIV/AIDS program, HIV/AIDS Bureau, but also through the Bureau of Health Workforce, which funds geriatric workforce enhancement programs and a geriatric academic career award program. Those are things that we can kind of utilize to make sure that we're training folks around aging needs, as well as making sure that folks who are aging professionals know about HIV and the community of folks who are living with HIV. And then I think lastly, there's a lot of stuff that's being done through the Ryan White program in terms of just making sure that there's core competencies around HIV care for providers, but more can be done. And so there could be opportunities to utilize the SPINS program so that we can, again, develop new approaches, both for supporting the clinical workforce, but also supporting the non-clinical workforce. So again, all those other wraparound services that we know are critical. The last one is around just providing more resources for prevention and treatment messaging, healthy aging campaigns, and research focused on older people living with HIV. We know that almost 1 in 6 people of new diagnoses in the United States are among people age 50 or older. So people living with HIV who are older are having sex or in other ways contracting HIV. So we need to make sure that we are getting HIV treatment, HIV testing and prevention services to those folks, and making sure that we're training providers so that providers don't have these mistaken assumptions that folks aren't sexually active or that they're perceiving them as lower risk. So making sure that they're actually talking to folks about their sexual health and about HIV, and making sure that our CDC programs are really spotlighting doing social marketing and kind of raising the needs and the issues of older folks in our communities. I think, yeah, if we just had a more diverse representation and programs that are particularly focused on older people living with HIV from the CDC, I think that could go a long way to addressing, again, a range of issues around HIV, aging, and related stigma. And we just need to, kind of also figure out ways to do more in terms of what NIH, so the National Institutes of Health, are doing in terms of having a coordinated kind of research response that looks at a range of issues, including social determinants of health, other social and behavioral issues, psychosocial issues, as well as implementation science. So making sure that we are in a position to facilitate the uptake and sustainability of some of these geriatric HIV programs that I mentioned, like the Golden Compass program in San Francisco. How do we think about actually taking that to the real world, bringing it to scale, and making sure it's sustainable? What can research help us do around that? And then kind of the last piece is just around, hey, where we have models that are doing well. So within the Department of Veterans Affairs, obviously, I think it's a mixed bag in different parts of the country where the Veteran Affairs hospitals and clinics are doing a really good job in some cases. Some probably still need to increase their standards and do better. But we have some models there that I think have worked well. And so just learning from those and kind of identifying best practices that can be applied in other settings. I think number two, I mentioned, is around community connection, which is just so crucial. We know that we see higher rates of stigma and social isolation among older people living with HIV. We also see that a number of older people living with HIV experience trauma or even violence, and this disproportionately is among experienced by women, by people of color, by LGBTQ folks. So we need to be addressing those in our response. I think there's a lot more that can be done in terms of just supporting social networks. So by expanding and strengthening people living with HIV networks, which I think play such a crucial role, as do other community-based organizations, so including aid service organizations, but also aging organizations, so agencies on aging, which exist throughout the country. There are ways to leverage those to, again, provide social support for older people living with HIV, as well as to make sure that we're tapping into faith-based organizations that particularly a lot of older people of color, so Black, Latinx folks who are living with HIV, they're in churches. So those are already networks that they're accessing, but those networks can be leveraged to make sure that we're addressing, again, the combination of HIV and aging issues that folks are experiencing. And so we need more funding to go to these organizations, and we really need to make sure that we're bringing folks together. So making sure that folks aren't isolated, that they can kind of stay active and participate in their local communities. And then I think there are ways to kind of leverage technology to support social support and social connection. So, obviously this has definitely been something that's happened a lot through the COVID-19 pandemic that, we've all been living through over the last year and a half, finding ways to have folks connect, not just for medical services using the phone or their computers or their, smartphones, for instance, but also being able to connect with others in their community and to get the support that they need. And so really taking advantage of that, though, also includes a need to overcome barriers that older people living with HIV, as well as the organizations that kind of serve those folks, sometimes face in using technology. So making sure that folks, one, have the access to technology so they can afford it if they have income or other kind of limitations to being able to get the technology that they need or to pay for phone minutes, things like that. But also just, supporting folks who might have less familiarity with using smartphones or using computers to access not only medical care, but really all the support services that I mentioned. Number three is around, again, Medicare Part D. Medicare is now the largest source of federal financing for HIV care and treatment. And so it's spent the most money of any federal program on HIV care. The Medicaid program, which kind of complements it, does actually reach more people, but we're spending a significant amount of money through Medicare. And most of the spending through Medicare goes to the Part D drug program. And so that program is critical for paying for antiretroviral therapy and other medications that older people living with HIV utilize on a daily basis, and that are critical for them to live and to live well and live healthily. Right now, there are protections within the Medicare Part D program that require at least 2 drugs per class on formularies to be covered, and to require coverage of substantially all drugs in 6 protected classes. And of those 6 protected classes, that includes antiretrovirals. And there are also additional protections for antiretrovirals that say that health plans may not permit or are not permitted to require prior authorization or step therapy to restrict access to antiretroviral therapies. Those are critical protections that have been in place, really since the beginning of this program, but that continue to be under threat. And so we saw during the Trump administration a few attempts to remove those protections. Fortunately, the Biden administration most recently, just in the spring of this year, rescinded kind of a proposal from the Trump administration to remove those protections. But we know that we could see similar types of action, either administrative or legislatively in the future, because we've seen these types of attacks on the Medicare program many times throughout the history of Medicare, and particularly around Part D for drug access. So we need to make sure that folks are aware of these protections, are advocating for them when they're going and talking to their federal legislators. We want to make sure that we keep those protections. In addition to keeping protections, so maintaining the status quo of protections that exist, we need to make sure that we're focusing on high quality care and quality of life. And so there's a lot more that the Centers for Medicare and Medicaid services can do, so CMS can do, to really take a proactive approach to meeting the needs of older people living with HIV. I think one of the critical things is, hey, how do we think about reimbursement schemes that allow for folks to have enough time with providers? So when you have multiple comorbidities, maybe a 15-minute, or 20-minute visit is not enough. You need significantly more time to address all those needs. How do we ensure that reimbursement through the Medicare program allows for that? How do we ensure that the Medicare program is really focused on addressing quality of care? How can we improve the kind of quality measures that are within the rating systems within Medicare to ensure that we are getting quality performance? And maybe there are better ways to measure outcomes and to incentivize high quality care within the Medicare program. And then we also just want to make sure that there's a focus on within Medicare on people like older people living with HIV who often face multiple chronic conditions. Make sure there's a focus on that population, and make sure that Medicare, CMS is supporting and working with providers, with health plans to make sure that they're integrating social determinants of health into electronic medical records so we can better monitor social determinants and respond to them. We also highlight just the importance of long-acting HIV treatment and prevention products that some of which have been approved. We had our first approval of injectable cabotegravir and cabotegravir at earlier this year, which is great. And so that is an opportunity to, again, no longer have to take medications, oral medications daily, but rather to get an injection, once every 4 or possibly 8 weeks. And so that has the potential to, I think, benefit older people living with HIV. So we want to make sure that we're thinking about how do we make sure that Medicare and all of our different payers that exist out there are not putting up barriers to folks accessing these types of services, and so that they are actually financially affordable and accessible for people living with HIV, particularly those who are over the age of 50. Number 4, allocating more resources to programs that support, again, financial security and addressing these broader social determinants of health. We need to create employment opportunities for people aging with HIV, including within the HIV workforce. Again, there are so many challenges to employment, including discrimination against people living with HIV, but also we just have programs that exist out there that if you make too much money, it essentially disincentivizes you from seeking employment, because your income could essentially mean that you might not receive certain public benefits. And so that disincentivizes folks from seeking employment, even though we know having a job, having employment is associated with positive improved health outcomes. We need to have increased funding for food assistance for people living with HIV. There's a lot more that can be done, I think, and a lot more focus on within the Ryan White program and within kind of local planning to think about where food assistance, what are the needs of older folks living with HIV, to track that and to make sure that funding is going to those services. Increasing financial support for addressing housing, so housing needs, housing insecurity among older people living with HIV. We know that housing programs are never appropriately funded. And so we need to make sure that we're getting funding through HOPWA, as well as to, again, the range of other housing programs that people kind of depend on. And then also just addressing navigation services to help older people living with HIV learn about and resolve issues related to Social Security and Medicare benefits. Both of those programs are very complex, and so we need to make sure that we have navigation services, as well as make sure that folks see the needs for advocating to change and expand those programs. There's federal legislation now that has been introduced around supplemental security income, so SSI income, which folks depend on just to have basic income assistance. So there's the SSI Restoration Act that would kind of expand that program so that hopefully it wouldn't cause as many problems for folks reaching income thresholds and possibly being kicked off the program if they make too much money. Currently, the programs really require you to live, really just at the federal poverty line, and so we'd like to be able to see that expanded so that it really kind of meets the needs of older people living with HIV and doesn't disincentivize them from employment opportunities. And then last but not least, we want to make sure that we promote the meaningful participation of older people living with HIV in the Ending the HIV Epidemic Initiative. So that involves engaging with government leaders on HIV and aging issues, and not just at the national level. We have things like AIDS Watch. We have kind of state and local AIDS Watches. Engaging with your local and state officials as well on the needs that you're experiencing around HIV and aging. Making sure that we also have a diverse representation of folks within our HIV decision-making processes, so specifically within our Ryan White planning councils, really empowering folks to to speak up and to use their voices and make sure that that is part of really informing the direction of the HIV response. And then really just making sure our advocacy efforts engage people and organizations outside of the HIV field. There are so many issues that aren't just HIV specific, so working with aging groups, working with LGBT groups, working with disability groups, I think is going to be key. And so again, these could be on different issues from Medicaid expansion to making sure we have community-based long-term services and supports so that folks can, again, age in their homes and have the support that they need kind of around long-term planning and long-term health. Making sure that, again, barriers to employment, our public benefits don't exist. So fighting those types of things and making sure that we continue to have funding for our community-based organizations, including people living with HIV kind of networks and organizations. So those are all of our kind of main recommendations. I think we'll have some time for some comments and questions. I think we should have about 15 minutes for that. So again, thank you all.
Thank you, Chan and Jeff. That was a great presentation, and we do have a lot of questions. So what I'm going to do, I'm going to keep going through them, and we'll let you know what the question is, and either one of you responds. All right. Let's see. Give me a minute. Okay, so the first one, I have a comment and a question from Jesus Guillen. He's from San Francisco. And he said, why do many agencies and organizations, including some doctors, keep saying we are living a longer and healthy life, while especially HIV long-term survivors, we are surviving with lots of challenges? We are the only proof of living with HIV and medicines. I can see his questions. I mean, it's kind of a statement and a question, but go ahead if you want to make a comment about it. I'm sorry about that.
Did you want to start, Sean? Or?
I mean, yeah, we have seen some successes. Obviously, we've had success in terms of the medications that exist now that are allowing folks to live longer lives, which is very good, and we want to make sure that folks continue to have access to those medications. Again, we do have high, we're increasing over time. I think our viral suppression rates, we actually have slightly higher rates among older folks living with HIV, but again, even those rates are still not high enough. So even with older folks living with HIV have higher rates of viral suppression, those still are not, we have not met the 90-90-90 goals, for instance, for the UN, which again, that's even leaving some folks behind. So we're nowhere near that for older folks living with HIV. So obviously folks are still, still face needs just around HIV access and retention and care for HIV. But if you are just focusing on viral suppression rates, you're like, oh, older folks are doing well. But when you, again, span the focus to think about all the other issues that we've all been speaking about in terms of comorbidities, social isolation, all the kind of structural and economic issues that folks are facing, folks aren't doing as well. And so I think there probably are some, misunderstandings because we focus so much, on kind of the care continuum and viral suppression that kind of probably leads folks to kind of think one way. But what we really need to be focusing on, I think, is kind of at the core of our report is, again, quality of care, quality of life, and addressing the comprehensive health needs of folks. And so if we do that, I think in terms of framing it, we'll be able to really present this full picture to doctors and to everyone to know, what are the issues that we still need to really do a much better job on. Jeff?
Yeah, I would just say really quickly, I think part of it is like, why do we give these messages? We give these messages to motivate people and encourage them to get diagnosed and get into care and stay in care. So I don't think it's helpful to say, even if you do all these things, it's going to be horrible. But I think we could acknowledge that despite our significant progress, as we're saying, some people are left behind and some people feel ignored. So I think we can give both messages.
Great, thank you. The following question is from Jack Skelly from California, and he just mentioned that, Chan, you were in California talking about the report recently, and that the people with HIV aging that were there, they were talking about the Compass program in terms of the reference that you make to it. And the question that Jazz has is, did support for caregivers come up in your research, and how was it addressed? And then, he goes explaining how, during the hard years of the 90s, community organizations, we created the field. We started, to identify the services that our friends needed, and we went ahead and did that. So he's asking, in relation to that, what has been done now in terms of identifying services and, kind of like advocate for them in a way that is, is effective and doesn't overlap with other kind of services for aging people that are already out there.
So I think I got the second part. Just to make sure, did you say something about caregivers at the beginning, or just around advocacy for HIV?
Advocacy about it, and also, the design of the service.
Yeah. So we did. So I've had an opportunity since releasing this report to speak to kind of planning bodies and committees like in California and a few other organizations and coalitions. And so we're going to hope to speak to more folks to share the outcomes of this report. I think where we need to be thinking, obviously, is from, hey, these are things that need to go to actually making the kind of change happen on the ground. And so we need to make sure that one, there's funding to support kind of advocacy, community-based advocacy, coalitions coming together. And so that's critical. And so finding ways to, again, work with us to make sure that folks not only are able to get funding that they need, but to really know kind of the key issues kind of at the local, state, and federal level, I think is really key. And so this is where I think we need to see kind of going forward, groups like this, groups like the one in California and elsewhere, to kind of push for that advocacy. And happy to obviously be in touch with Jackson, you, and anyone from this group and elsewhere to make sure that we're continuing to make that happen. For the Compass program, again, those are kind of clinical programs that exist. I think they do connect folks to kind of social programs that exist kind of locally, including for kind of all of the kind of supportive services that I mentioned. I think it's really critical that they be able to connect folks to community-based organizations, as well as some of these national and state level kind of people living with HIV networks, so that folks, again, aren't feeling like they're in alone, but they can feel that they have a connection, and also can engage in the types of advocacy, strategizing that kind of needs to happen, because this movement will need to be led by, and should be led by, older folks living with HIV. And so those types of programs, as well as folks like myself, need to continue to support and empower and find ways to make sure that more of that happens. So Jeff, did you have anything else you want to add to that?
No, I can, that's good.
That's great. So the next question is from Thomas Villa, and the question is, a major challenge is that, the federal role for most program services is to provide guidance and funding. It's then up to the individual states, that's good, and localities to choose to provide services and apply for funding. He's mentioned that, all those people living with HIV are in a relatively aging, right? Older people with HIV in a relatively small group and lack critical mass in many cities and states. How do we get the states to act? I'm just going to start saying, Tom, that's one of the works that we will be doing from the network, and you're part of the network, is to actually mobilize people and find that critical mass that we need. And there are other initiatives like, the Reunion Project and others that, we can, among ourselves, all organize to build that. But then, the issue about federal and states. Go ahead, Sean or Jeff.
Yeah,
I can jump in.
Go for it, Jeff.
Okay. Yeah, so I have two reactions. One is within the HIV community. I think our own community needs to do more. And so I think there it's really about elevating this issue with planning councils and in local communities, and we really need to expect more. I think with these broader coalitions, I think there's a couple things. One, we do just need to build partnerships and help these other parts of the aging community understand our unique needs. But I work in disability, and there's often this perception that like we're the lucky ones, we have all these resources. But then when you get to aging, one of the dynamics that's different about our community is people haven't built up the same level of assets that other aging people have. So in some cases, we're at a great disadvantage. So just helping people understand, because they might come in thinking, you have Ryan White, you have all these other resources, not really understanding the extent of our needs. And so there, I just think it's partnerships with these broader groups. I think once they get to know us, it's not that they're not going to care, they're going to want to support us, but they don't necessarily know what our challenges and our needs are.
Right. Sean, you want to add something?
No, I think that's great, and happy to go on to make sure we get to as many questions as possible.
Perfect. Thank you, Jeff. Okay, so I'm trying to browse through the statements and then the questions. This guy's from Austin, Texas. Is Barry Waller, and he said that, you know, they over there they have brought together the HIV services and the aging services in the community to hold 6 seminars online to talk about their services, so both of these communities can become familiar with each other, and they have not been talking to each other. That's like another example of something that we can do at our local level, as Jeff said. Thank you, Barry. Do you want to add to that, Jeff, or that's okay?
I agree with that point, though.
Me too. So okay, so then we have from Michelle Lopez said, would there be any congressional hearings to move forward with some of these recommendations that are needed? I can speak a little bit to that, but I will let you go ahead.
Well, I was going to say, and Sean, you can jump in, but like we're not advocates, so we try to like leverage our resources, but we really look to NMAC and other the national advocacy organizations. So Moises, tell us what you think.
Okay, so yes, I mean, I'm glad we have something to say about that. I have been working with the Director of Government Relations and Policy at NMAC, and actually we have been in a process since last year to advocate for a congressional hearings on aging. So we have met with the Senate Committee for Aging, and we already had a meeting with Scott, and the other one, I'm blocking the name, who is the actual chair. That happened when you age. So anyway, we've been talking to the chair and the ranking member of the committee about, you know, coming together and sponsor one congressional hearing on aging and HIV. I think the last time that happened was in 2012, and I think it was sponsored by AMFAR, and there was, you know, there was discussion about how the administration need to prepare for that. But I think at this point, we already have the issue with us. So we have been having conversations about joining another, you know, comorbidity, other diseases, and have like a joint congressional hearing. But also on the other hand, we're making the case to have one specific related to HIV because of the complexity of the issues and that exist out there. And one thing that caught the attention of the ranking member staff is, you know, when we talk about comorbidities, you know, one of the main issues is not only that we will have more comorbidities, you know, and on top of HIV, but that also some comorbidities we'll see them to happen earlier. So people in their 40s and 50s are having to deal with these comorbidities when people that are HIV negative usually get them when they're 65 and 70. And in that in between, when they are in the 40s and 50s, not even taking Medicare because they're not 65, there is not any kind of standard of care or protocol for them because Ryan White just addressed on the, you know, viral suppression and the, you know, the primary care stuff that the patient with HIV need. But we need to figure out a way in which that screening of comorbidities happen earlier. So there has been issues, and I'm sorry I went on the side, Michelle, but yes, we're working on that. Thank you for the question. There is a lot of thank you notes. People are very happy. So We have another question from Thomas Vilas. How do we reframe discussion of our needs as older people living with HIV so that we are not seen solely through the lens of the federal plan to end the HIV epidemic, which ends at viral suppression? That's a good question. Guys?
Do you want to start, Sean, or do you want me to?
I mean, I'll let you go if you have some thoughts. I mean, I think my key thing is just that we need the federal plan. We need to make sure that we're informing that federal plan and obviously making sure that it is responsive to the needs of people living with HIV. So when we think about any HIV epidemic, when we think about the national strategic plan as well, like those need to be, centered on and thinking about obviously the needs of folks. But there's so much more that needs to happen at the local level. And I think kind of working through planning councils and having that work kind of, not only influence what's happening in the community, but also inform up, I think is critical. So. Yeah.
And I would just say a couple of things. One, I don't think we ever want to sound like almost resentful that we're focused on viral suppression. I mean, think about the early days that many of us remember, and we should be so grateful that we have so many effective treatments. And I just think that the way we motivate people is to get them to buy into our success. We started with a condition that devastated our communities. We've made so much progress, and we need you to help us get the job done, and we're not done. So despite all the great things we're doing biomedically, the systems we put in place, there's still these gaps or these unmet needs that we need to take on, and we need you to help us with that. And I think that's a way to get people to care and see that this is something that we should all focus on.
Yes. Great answer. We have another question, and we have to wrap up. It's 3 o'clock. But we have a question from Jeff Berry. He, said fantastic presentation, and he said with the recent surge of the Delta variant, have you thought about what that means in terms of offering in-person versus virtual services, addressing isolation, or even incorporating that into our responses going forward? Ending the epidemic can't happen if we don't end the COVID epidemic.
Absolutely. I mean, so in our report, we definitely talk about COVID and the impact that it's having on folks. We need to make sure that we're having older folks living with HIV like inform all of the issues that are disproportionately impacting them. So not just COVID, but also STDs, hepatitis, mental health kind of challenges, substance use as well. So that's really key. In terms of work that we're doing at the O'Neill Institute, we published a brief at the end of last year kind of on telehealth and HIV. What are kind of the critical issues in terms of making sure that telehealth meets the needs of people living with HIV or impacted by HIV. So making sure we have access, obviously at a very critical level. So folks have access to the technologies, access to minutes and data plans and things like that. But also making sure that we are kind of informing both the federal and state policies, the regulations that exist around reimbursements, hopefully how those will look kind of going forward. All of that's going to be critical. And so I think there are ways to think about, hey, not just telehealth in terms of medical care, but how can we be leveraging just technology to kind of support kind of social engagement and kind of breaking down social isolation. Jeff, was there anything else that you want to say?
Yeah, well, first I'd say, hey, Jeff. Yeah, just to build on what Sean had said, I also think that we need to think of telehealth of like we did something in an emergency response. We need to all figure out like what's a sustainable model, and it really shouldn't be about replacing in person, but it's like adding to options for people and making that work. But I also think our community of all needs to not get ahead of the data. And so I have a lot of critiques about how we've communicated public health ideas. I feel like how we've talked about hesitancy has fueled hesitancy. So I think we need to be careful talking about these Delta variants and in a way that scares people. We know if you're vaccinated, you're protected now. It could be in the future that we have greater concerns, but I think we don't need to start telling everybody that all these things are happening. We need to wait for the science. But I think what COVID has shown us, we need to build in a lot more resiliency into our system. So telehealth is just one aspect of that, task shifting, other things. And those are things that, we all need to just keep thinking about because who knows what are going to be our challenges next. It may not be COVID, it could be some new thing. And we just need to have more flexibility to respond.
Yeah, and I want to add quickly the whole thing about telehealth, also the technological, there are differences in people that have access to a smartphone or to a computer. We made the assumption that everybody has access, but that's not the reality. And my concern is that I think telehealth will help, but also, as Jeff said, we need to think bigger than that in terms of what other options we provide to those that don't have the computer. Maybe we need to look at infrastructure issues as well that can facilitate Wi-Fi, computer, smartphone, so the health disparities don't get exacerbated with new technology, which is one of my biggest concerns sometimes. So we are at 3 o'clock. We still have questions. We can write them down and address them, and we can do all that online. I don't want to, I'm sure we're all busy people and we have things to do. So I want to respect your time. I want to thank Sean. I want to thank Jeff, because Jeff said we're not advocates. I always will see you as an advocate. It's like
maybe
Sean,
a little bit.
and Sean as well, but to be an effective advocate, you need information. You need to be informed. And that's why, when I see the work you do with this policy brief, you're giving us, ammunitions to be effective advocate. And in a way, that's way of advocating and working with the community, which I greatly appreciated. And, this is something that we will take with us, and use it as a tool to be effective in the advocacy that we want to do. So thank you again, and I close the session, and everybody have a great week, and thank you very much. Talk to you later.
Thank you so much.
Bye-bye.
Bye.